rely more on mechanism, and then you look at the underlying drug that is relevant, and then the site of infection that you're choosing it for. So, when we are dealing with these bugs, why is our response to therapy or the outcomes poor? First of all, understand that in the beginning, if you do not cover your empiric regimen for difficult to treat or CRAB, you would obviously not get the desired outcome, because there's going to be a delay in initiation of appropriate empiric therapy for that matter. You're dealing with higher bacterial burden. Then, uncertain diagnosis. A colonizer you thought of as infection and vice versa. So if in a true infection you've left it as a colonizer and not started treating, then of course the outcome would be not as desired. Then PK failure. We have patients who are in septic shock, who have capillary leaks, so augmented renal clearance, high MIC, all of this, if the drug does not penetrate the site and you have not chosen the appropriate infusion strategy and the appropriate dosing, you will again not get the desired outcome. Then with toxicity of drugs like polymyxin, like the nephrotoxicity, it limits the exposure because you have to modify the doses in cases of colistin. Then source control. Remember, if you do not achieve source control for any underlying infection, no matter what you do, your antibiotic therapy, no matter what principles you use, will only partially support you in infection control. So source control is always equally and more important when you are dealing with a patient with any infection. Now, how do you differentiate whether it is actually an infection or a colonizer? So when would you think of it as an infection, and when would you want to treat? When you have a patient who has a new progressive infiltrate, has worsening hypoxemia, is becoming a colonizer. So you need to be able to look at the patient clinically as well to really understand and differentiate and not treat a colonizer, because that is only going to increase your antimicrobial resistance. Then at the bedside, when you are actually dealing with such resistant bugs, what would you do to have a proper workflow? First of all, always confirm that you're dealing with a true infection. We just talked about it. Understand the syndrome, the severity, and what is the source. Then read the antibiogram. Understand the mechanism, especially like I just said, Pseudomonas has multiple mechanisms, and it has the ability to change the resistance pattern while on therapy. We'll understand as we go ahead. So unless you understand the mechanism and choose the drug, if you've given ceftazidime to such a Pseudomonas isolate, you might not be able to achieve the desired outcome. Then match the site. You've chosen a drug but it does not penetrate the site, and the MIC is not appropriate. So then again, you will not get the desired response. Control the source. I think we've talked enough about these in the previous lectures as well. You need to achieve source control and always reassess. No matter what you're dealing with, if you start a therapy at 48 to 72 hours, you must assess for response, toxicity, and repeat AST in certain situations, especially in cases of Pseudomonas with AMC. We will discuss as we go ahead. So beginning with difficult to treat Pseudomonas infections. Now Pseudomonas, like I said, has the ability to develop resistance with multiple mechanisms. It can prevent the entry of an antibiotic into the cell wall, throw the antibiotic out because of the efflux pumps, then enzymatic degradation, and prevent protein target binding. So the mechanisms in Pseudomonas resistance are layered. It is not a single enzyme. Loss of the porin OPRD channel. So what would it do? It would prevent carbapenem entry into the cell, and drugs like imipenem and meropenem would have higher MICs there. Makes efflux, so drug would get pumped out. So your drugs like fluoroquinolone, meropenem, astronam will become ineffective. Then the PDC-AMC that I've been talking about. Now Pseudomonas resistance, like I said, develops through various mechanisms, as you can see. These mechanisms can emerge while the patient is on the antibiotic. So if the patient deteriorates while on a therapy, you need to understand that this could be because of the PDC-AMC change, wherein it hydrolyzes the beta-lactams. So if you gave the ceftazidime, because of the ceftazidime and because of the AMC production, this will become ineffective. So in such a circumstance, remember that if you are dealing with such a mechanism, one, of course your drug has become ineffective. Second, your patient will start showing signs by, again having relapse of infection, or persistence, or the recovery has slowed down. And in such instances, you must send a repeat AST, because now you're probably dealing with a completely different mechanism of resistance. Then we have carbapenemases, which cause enzymatic hydrolysis. So this is especially important in case of the MBLs. Then the problem of target and the target change and biofilm formation. So obviously there will be more persistence. So again, more relapses and more resistance to the therapy while the patient is on a certain antibiotic. So you need to remember that Pseudomonas has multiple layers of and multiple ways by which it can develop resistance. Now when you look at in the Indian Pseudomonas, if you look at this and you see that only 23% of the isolates had actual carbapenem resistance, and out of them only 10% were NDM and about 4% had VIM. The 80%, the rest 80% were actually negative when they were screened for carbapenem resistance. So understand that most of the carbapenem resistant Pseudomonas isolate are PCR negatives, and resistance is commonly due to the multiple mechanisms that we talked of pore channel, efflux pumps, and CNPTC. So in case of Pseudomonas, you need to treat the mechanism and not just the resistant phenotype. Understand that carbapenem resistance is a phenotype, and carbapenemase production is only one mechanism behind that phenotype. There can be multiple mechanisms. So your therapy has to be dependent on the mechanism that you're dealing with. Now when we look at an antibiogram, what does it tell you? Now if you have a culture sensitivity report which is showing you that your carbapenem is resistant and cefepime, ceftazidime and piperacillin tazobactam is sensitive. So this tells you that you're probably dealing with an pore loss and an efflux mechanism as an underlying cause of resistance. And now in such a circumstance, if you have a traditional beta-lactam which is sensitive, you give that becomes your therapy of choice in a high dose extended infusion. Next, if the report shows you that there is carbapenem resistance, cephalosporin resistance or a fluoroquinolone resistance, this means this is a layered structure. We just talked about this. Multiple mechanisms. So now you test for newer agents, you think about the newer agents and you consider carbapenemase testing in such a organism when it's showing you this sort of resistance pattern. Broad beta-lactam resistant MBL, if you have the NDM or VIM. So ceftazidime avibactam in case of this may not be reliable. Ceftericol, if available, is the most ideal drug that can be given for MBL Pseudomonas. And if you have a new resistance during therapy, I think I've already told you this enough, it could be because of the change of mechanism. So in such circumstance, remember you need to repeat the culture in AST and always look at your source control. You may need to even reassess for your source control. Now let us look at a case. A 58-year-old post-renal transplant patient with fever and dysuria, obstructed ureteric stent, blood and urine are showing you Pseudomonas aeruginosa. Patient is not in shock. Creatinine is okay, and he has a history of prior meropenem exposure. Now look at the report. As you can see that mero as well as ciprofloxacin are showing you are resistance, and piperacillin tazobactam, ceftazidime, cefepime, amikacin are sensitive. So we just talked about it in the previous slide. This tells you that the underlying mechanism of resistance is loss of pore channel and efflux pumps. You're not dealing with a difficult to treat bug. So what is a DTR Pseudomonas, which is non-susceptible to all of these following major first-line categories that are enlisted. So if you have any traditional anti-Pseudomonal beta-lactam susceptible, you must use it appropriately before you jump on to thinking of using the newer agents. When should you do carbapenemase testing? When you are seeing broader resistance, like I just showed you, it was resistant to all. When you are investigating an outbreak or doing a local epidemiology mapping, when you're thinking of possibility of MBL Pseudomonas, when patient has been on therapy but there is an unexpected failure in spite of the fact that you had optimized this therapy based on the initial AST report. So in such circumstances, you must think about sending the carbapenemase test. Now we all understand that we have time dependent, concentration and exposure dependent antibiotics. Now when we talk about time dependent, especially with beta lactams like ceftriaxone, you want it to remain maximum time over MIC. And that is why it is this class of antibiotics wherein you want to give longer infusions and adequate frequency to achieve the desired serum concentrations. For concentration dependent, the maximum one, like for aminoglycosides, it's the maximum concentration over MIC. So one large dose is sufficient for an extended interval. Then for exposure dependent, like polymyxin and fluoroquinolones, it is the AUC over MIC. So loading dose always followed by a total daily exposure. That is why it is important to understand the basic underlying how does the antibiotic actually work, so that you can actually decide upon the appropriate dosing strategy as well as the infusion strategy. And then unless you do that properly, you will not get the desired outcome. Now when we look at the extended and continuous beta-lactam infusions, we have been talking about the drugs. If you look at the major trials like the Mercy and the Blink 2 trial, these two trials did not show that there was any major mortality benefit. But when you look at the 2024 meta-analysis and you look at the prolonged infusions, you see that there was a high probability of mortality benefit across the RCTs. So when you ask me where would I choose prolonged infusion strategies for beta-lactams, it would be in patients where I'm dealing with high MIC, patients who are in shock, where there is the problem of augmented renal clearance, source control has not been adequate, and I'm dealing with deep-seated infections. So this is where prolonged infusion strategy becomes ideal. Now the factors because of which we see that you are not getting the adequate response. What are these reasons why you've started appropriate therapy but you're dealing with underlying problems because of which your patient is not getting better? Augmented renal clearance, trauma, burn patients, younger patients. So when there is augmented renal clearance, you would not achieve the serum concentration. So in such circumstances, you have to increase the frequency of dosing and maybe, if available, consider therapeutic drug monitoring. Capillary leak, large volume of distribution in patients with shock, then you're giving aggressive fluid resuscitation. So you must remember, give an adequate loading dose. Loading dose is very important. It does not need to be adjusted based on the patient's renal function. And this is very important. MIC at the break point. So, for this where your report says I on the report, that is when it means that maximum licensed dose and a prolonged infusion is what is needed. And then sanctuary sites. If you've chosen a drug that does not penetrate the site, for example, not related to Pseudomonas or Acinetobacter, but Daptomycin for lung infection. If you do not give the right drug for the right site and you do not achieve source control, if you don't drain that collection, your patient will not get better. You will not get the desired target attainment. You will not get the adequate infection control. So you have to keep these things in mind as well before thinking of the drug and then choosing the appropriate strategy. Now, when you're choosing the drug, like I said, it must reach the site. I was just stressing upon this. So when you're thinking of bloodstream infection, you always need a reliable serum exposure. For patients with lung infection, VAP, it has to have ELF penetration, especially in severe inoculums. So drugs like polymyxin and aminoglycoside exposure may become problematic. In urinary tract, if you have a drug with renal excretion, that can be advantageous. So that is why in certain circumstances, with selected UTI, we prefer using aminoglycoside and colistin. For biofilm and device, tolerance far exceeds the planktonic MIC, so you need to remove the source. Obstruction and abscesses, you need to drain, debride and unblock. Now, if you go back to the case, the patient had a sensitive beta-lactam. So I would choose cefepime and not jump onto aminoglycoside because that was also sensitive. I would give it in a high-dose extended infusion, and because the patient had a ureteric obstruction, I would want to achieve the source control as well. I would want to relieve that obstruction. And if the Pseudomonas does stop responding, like we've just talked about, then in that case, of course, repeat AST is
follow-up checkup within 3 days, max 4 days.
So when we talk about difficult to treat Pseudomonas and when we look at the treatment algorithm as a whole, first of all, always confirm and it's a true infection, most importantly. Any traditional beta-lactam is active, is a high dose extended infusion. To test for ceftazolone, tazobactam, Cas-Avi, Relebactam, and cefderichol, but understand that these are not available. We only have ceftazidime and avibactam as of now available in our country. If an MBL is confirmed or strongly suspected, cefderichol becomes the validated rescue strategy. Again, not very readily available. For a non-MBL DTR, you choose an active newer beta-lactam. And for no active beta-lactam, if you don't have any beta-lactams available, then last resort is again combination. Now this combination would again depend upon the isolate, the mechanism that you're dealing with, the site of infection, and then of course the dose that you chose depending upon the MIC, and everything has to be considered. And source control always. So when we look at the traditional beta-lactams, we have cefepime, which is when you have a cephalosporin susceptibility in a carbapenem-resistant Pseudomonas, this becomes a good option. But there is a problem of high MIC and neurotoxicity in renal dysfunction. For piperacillin tazobactam, when you have a clear susceptible isolate, you can use it. But breakpoint infusion assumptions have to always be considered. For ceftazidime, in the case of a susceptible isolate, but we just talked about the AMC, so there is a higher risk of, you need to remember this risk when you're selecting ceftazidime. Astronam for selected isolates in MBL, but it can be destroyed by co-production of serine enzymes, and efflux may also raise the MIC. Aminoglycoside for selected UTI or as an adjunct when no beta-lactam strategy is available. But remember not to use it as a routine monotherapy for pneumonia and bloodstream infections. Then the newer agents, we have ceftalazone, tazobactam. Now newer beta-lactams are more mechanism specific, like ceftalazone, tazobactam for non-MBL, difficult to treat Pseudomonas, and PDC and permeability phenotypes. Now this has an advantage, it is effective in the PDC and permeability phenotypes. Ceftazidime avibactam for some DTR Pseudomonas if you have the susceptible report. But the major gap is with the MBLs. Imipenem relebactam for imipenem resistance driven by PDC and permeability where AST is active. Then cefderichol, we just talked about cefderichol for MBL producers and broad DTR. And then we have the cefepime zidebactam, which has a dual PBP activity and it is potent in vitro. So I'll talk about this as especially about zidebactam. A word before that about the MBL producing Pseudomonas. Now understand one thing about MBL producing Pseudomonas, that they have the ability to destroy carbapenems and most of the beta-lactams. So avibactam and relebactam do not inhibit MBLs. So if you have a susceptible isolate, cefderichol, if available, becomes your drug of choice. If not, then astronam plus a DBO strategy becomes your therapy of choice. So like we apply in enterobacterials, you cannot apply the same MBL algorithm blindly to your Pseudomonas species. That is why it becomes very hard to treat this particular phenotype. And I was talking about this cefepime and zidebactam. So cefepime and zidebactam has now been FDA and India approved for adult complicated UTI and pyelonephritis for the susceptible gram-negative isolates. And it has potent in vitro and compassionate use activity against both Pseudomonas and crab. It has both. So cefepime has PBP3 activity and zidebactam has PBP2 activity. So that is why it is the dual PBP beta-lactam. That is why it is called the beta-lactam enhancement. But remember, do not extrapolate it automatically to a ventilator-associated pneumonia or bloodstream infection or for every DTR isolate. But this is now available and this has been approved by FDA. So over time, I think this would actually change the treatment of specifically for the difficult to treat patients. Now a word about the combination therapy and synergy. Understand if you're using two inactive drugs together, that does not make it a one active regimen. So do not add a second drug routinely when you have a good beta-lactam which is active and it is available. And consider last resort combination when no beta-lactam demonstrates activity. Choose beta-lactam with MIC closest to the breakpoint, not with extreme resistance. Use synergy testing only if the result will change the deliverable regimen, and judge concentrations against achievable serum and site exposure. So for Pseudomonas, TTR Pseudomonas, carbapenem resistance is not synonymous with DTR. Carbapenem R cephalosporin S usually points to loss of porin channels and efflux. Use a traditional active beta-lactam with high dose prolonged infusion before escalating. For difficult to treat infection, test for all the available options, but we only have ceftazidime avibactam available. MBR Pseudomonas is a distinct Indian challenge, and AST and local epidemiology are essential, and no antibiotic compensates for source control failure or an unreachable PK target. Quickly about the carbapenem resistant Acinetobacter baumannii. Carbapenem resistant Acinetobacter baumannii, or when we talk about Acinetobacter, it not only succeeds, it survives in the ICU because it can last for weeks on dry surfaces. It has the capacity to form biofilms. It can evade the host immune system. Because of the Acinetobacter, even in poorly nourished state, it can continue to grow, and it has genetic plasticity. So it not only succeeds, but it succeeds because it actually survives. And we know that it dominates in ventilator-associated infections, but it is not just that. It is in bloodstream, secondary to line infections, in wounds as a colonizer or as a deep invasive infection, in CNS, especially in post-neurosurgical patients, in bones and devices because of the problem of biofilm or prolonged therapy, and in urinary tract, often it is catheter-associated. There are multiple mechanisms that are associated with CRAB resistance, and it is cumulative. You have oxacarbapenemases, ADC cephalosporinase, CARO porin loss, efflux pumps, PBP and lipid A changes, as well as biofilm and heteroresistance. So when we talk about the Indian crab, and when you look at the molecular epidemiology, you see that if you look at this, you see that 86% are carbapenem resistance isolates, and out of these 38% had OXA23 alone, and 36% had OXA23 and NDM co-production, and only 21% were screened negative. So why this matters in India? Because we say that we want to use the sulbactam-durlobactam strategy, but durlobactam inhibits the class A, C and D enzymes, but not NDM. And CRAB in India has a lot of NDM co-production, as you can see, almost 36%. So co-production and the PBP changes may reduce the reliability of a single mechanism-based assumption. So you obviously need to obtain the AST and interpret based on the infection site, but this is an important aspect, and that is exactly why this co-production matters a lot, and the reason why we want to give the sulbactam-durlobactam combination, although in India we don't have it, and we use more of ampi-sulbactam. So, if you look at this patient had a third tracheal aspirate growing crab. And when I look at the clinical trajectory, he's improving, except for the chest radiograph. Now remember, you do not chase radiology. You chase the patient's clinical trajectory. You look at the clinical positioning. You see how the patient is responding. Since this patient was getting better, the whole thing now, the positive third tracheal aspirate would be because of the airway or device biofilm shedding. So in this such a situation, a patient on day 9 of ventilation and who's improving, I would not, because I've isolated a crab again on the third tracheal aspirate, start polymyxin solely based on this culture. This is only going to add to nephrotoxicity, and it's only going to increase resistance. So I am not going to just blindly rely on the report. The only purpose of showing you this is that you have to also look at your patient's clinical trajectory and correlate it, not just blindly start treating the reports that are available. So what are the basic treatment principles for moderate and severe CRAB? Preferred is sulbactam, durlobactam and imicelestin wherever it's available. We only have meropenem. If unavailable, we generally use high-dose ambi-sulbactam and a second active agent like polymyxin and maybe addition of minocycline or TG, and cefderichol, of course, wherever it's available. In severe crab, avoid routine use of meropenem, colistin, rifampin, fosfomycin and nebulized antibiotics unless you have a specific rationale. This is very important and this should always be remembered as the main strategy for crab infections. Now, sulbactam is the antibactericidal drug because it binds to both PBV1 and PBP3 especially. So it causes the active killing. But resistance can emerge when OXA and ADC enzymes hydrolyze sulbactam before it reaches the target. We generally use high dose ampicillin sulbactam, which is available to us in our setup. We don't have sulbactam durlobactam. And when we talk about the sulbactam durlobactam as a strategy, now understand that why you want to use durlobactam, because it actually protects your sulbactam and it is the sulbactam which causes the killing of your Acinetobacter. So what does durlobactam do? It inhibits the class A, C and D beta lactamases and it protects sulbactam. So sulbactam can cause the PB3 and it can cause the killing. This is what is very important, but durlobactam does not inhibit NDM. So local mechanism still matters. So you need to remember this as a strategy and why this combination is preferred. Then the ATTACK trial, which was done for sulbactam, durlobactam versus colistin. The only important thing about this is, although there was no inferior mortality because mortality, clinical cure and microbiological response was near about, similar. It was in nephrotoxicity, which was the least with this combination when it was compared to colistin. But most of these patients also received imipenem celestin. So generalizability to Indian NDM co-producing crab requires AST. Because our crab has a lot of NDM co-production. So you need to remember this and prefer if this combination is available. It also has the advantage of low nephrotoxicity. Now, when we look at polymyxin and colistin, we all know about the use of polymyxin B. They both do cause nephrotoxicity and even neurotoxicity. And best position for polymyxin B is in combination with for non-urinary crab, and that for colistin is in selected urinary infection. Then there were two randomized large trials wherein colistin alone and colistin and meropenem were compared. This is another very important strategy. A lot of Indian ICUs and a lot of habit is to keep adding meropenem to colistin. So there was no survival benefit which was seen by adding meropenem in these two large RCTs, and higher mortality persisted with both the strategies. So do not add a carbapenem routinely to a colistin based crab regimen. Of course, there is an exception of carbapenem which is used with sulbactam and durlobactam when recommended. So just adding meropenem blindly to a colistin containing regimen for a crab is not going to give you any additional benefit. Now when we look at minocycline and TG-cycline as the tetracyclines in crab infections, minocycline is available in both oral and IV and TG-cycline IV. We understand that you do not give monotherapy, it is always given in a combination therapy. Minocycline is best in tissue infections and pneumonia as a combination, and TG-cycline for complicated intra-abdominal infections as well as pneumonia. A word about cefdiericol. Now cefdiericol has, it enters using the siderophore iron uptake pathways. So what it does is it basically bypasses the porin loss mechanisms. So this is why it can retain activity despite several crab resistance layers. And it remains, but your use has to be, it has to be, you have to be cautious despite the strong in vitro potency. Most importantly, as of now, it is not available, but it is a very effective drug if needed in certain isolates of crab. Then the emerging crab options, we have the cefepime zetibactam. I think this is going to change and revolutionize treatment over time for these difficult to treat bugs. because it has both dual PB3 and PBP2 activity, and it's potent in vitro activity against many oxa-producing crabs. Then we have the sulbactam durlobactam, which is the pathogen target. Strongest randomized evidence has been seen in hospital-acquired infection and ventilator-associated infection for serious crab. But remember that NDM and PB3 mutation can confer resistance. So the use has to be, once it's available, has to be monitored. Then when we look at the crab therapy by syndrome, you know that for HAP-VAP we have ampicillobactam is the high dose ampicillobactam is what we use. But of course, sulbactam, durlobactam and carbapenem wherever available. For bloodstream, again sulbactam centered combination. CNS infections, specialist regimen, intrathecal and intraventricular strategies only in selected rescue cases. For UTI, you confirm through infection, and colistin may be preferred, is obviously because it has renal excretion. And for bone device and wound, again sulbactam centered therapy in combination. And of course, you need to achieve source control. So, crab control is more than antibiotics. We all understand that. You need to reinforce hand hygiene, contact precautions, environmental cleaning. Unless you reinforce these strategies in your ICU, it is very difficult to get rid of crab. And once it's there, it tends to remain. Device minimization, unnecessary device lines, catheters should always be removed. Surveillance should be always in place, and antimicrobial stewardship, which is very important. So do not treat colonizers, and you must audit your polymyxin and novel agent use. So to summarize, when you are treating such difficult bugs, when you're dealing with carbapenem resistant Pseudomonas and Acinetobacter species, the treatment is based on mechanism, PK/PD optimization and source control. Do not treat a resistant culture before proving a compatible infection. Carbapenem-resistant Pseudomonas may still be treatable with a traditional beta-lactam if your report shows so. For Pseudomonas, you need to understand the underlying mechanism and look at the full antibiogram. MIC, dose, infusion, renal clearance and infection site determine whether this susceptible will actually be successful when you choose that drug. For crab, use a sulbactam containing regimen, and sulbactam durlobactam is preferred wherever available. Polymyxins are rescue components and not comfortable monotherapy solutions. Do not use them as monotherapy. Indian crab frequently carries OXA23 and NDM, and local data and AST are indispensable. Whenever you start a therapy, always reassess for response, toxicity, source control, and in certain cases of Pseudomonas isolates, you may need to do repeat susceptibility testing. Thank you.
Thank you, Dr. Akanksha, for taking the lecture, or exhaustive lecture on this. So we will start the today's session, and I'll introduce Dr. Ekta, who is going to moderate the session today. She is a professor and head clinical virology, nodal officer, WHO Collaborative Center in New Delhi. She is founder secretary of Indian Society of Clinical Virology, national coordinator microbiology teaching, and teaching resource person for National Viral Hepatitis Control Program, instrumental in implementation of viral hepatitis program. She's working in ILBS, and she's very active in virology, and one of the very few people who are working on virology so actively. She's got almost 30-year experience in clinical diagnostic virology, initiated DM virology and PDC courses, secure multiple national and international research grants, gold medal in MD thesis, and 150 plus publication. So over to you, Dr. Ekta, to conduct today's proceeding.
Thank you. Good evening to all of you, and thank you so much, Abla, for such a kind introduction. Without wasting the this report that you have created for the infections and the treatment part. So the important, I think it was the end of your gram-negative bacteria, and very nice to see that viral infections are being now talked about, especially in your IB forums, which is the talk of this decade, I can say. So, and a very important topic, that is pneumonia, lower respiratory tract infection by viral infections, as well as community acquired other atypical pneumonias. Because as you can see right now in Delhi also, we are seeing a lot of influenza cases. Typically, this post-monsoon season coincides with these infections. So these are very apt talk and immunization, very apt from today's point of view. So without wasting time, let me introduce the next speaker, who will be talking about these viral and other atypical lower respiratory tract infections. Dr. Nitin Bansal, and we are really honored to have him to deliver this talk. He's consultant at RGCID Delhi. He has been in All India rank 1 with CBSE, PMT, and especially the NEET PG so much in talk. So we are happy to have him on board with us, with a gold medalist in anatomy. He's been a COVID warrior, international observer, more than 40 full publications with first author and corresponding author, and faculty in 6 form. And his area of interest are in HIV, tuberculosis, especially the drug resistant, infection control, epidemiology, and infections. So it is a very nice topic that he would be teaching, that is viral pneumonias and other atypical pathogens. And over to you, Dr. Bansal.
Thank you, ma'am, and thank you, Chavla sir, for asking me to speak on this important topic. And I really appreciate the lecture taken before me by Dr. Chavla, Dr. Akanksha Chavla. That lecture was very exhausting, and I mean, it was very elaborative, and actually went through all the details of the two very infamous non-fermenters which are there in our ICUs. So we will be switching gears. We will be, I hope my slides are visible and they are in presentation mode.
Yeah, they are visible.
And so we will be switching gears to viral infections, as ma'am introduced, that we will be discussing viral and atypical lower respiratory tract infections in adults. And I don't have any disclosures to make. I will try to answer these 3 questions which I think are pertinent to a clinician. I will not speak too much about the virology aspect, which I think ma'am can take over whenever she feels like much more details are required. But from a clinician point of view, what is the epidemiology of viral and atypical LRTIs, particularly Indian data? When should we test for virus? Should we test all the patients? Should we look for specific signs and symptoms, radiology features? Or should we do blanket test for everyone? Or should we not do virus and assume that it's there? Or then what are the management of these viral and atypical LRTIs? So I was, in the briefing which I received, I was asked to keep some cases. Since I work in Rajiv Gandhi Cancer Institute, my cases will be from cancer patients, but don't worry, the principles of managing any infection remains the same, whether it's a cancer patient or something else. So the case one is a 54-year-old female with an underlying diagnosis of CLL, that is chronic lymphocytic leukemia. She has been on medical observation and not on any therapy for CLL per se. She presented with fever and cough for around 9 days, started with mild cold and nasal symptoms, that is some rhinorrhea and all, then progressed to cause dyspnea as well. She is a resident of Haryana, which is a housewife with no other comorbidity or significant past history. She was admitted to some other hospital before coming to us, where she was managed as community-acquired pneumonia, and she was given piptazo and azithromycin along with hydrocortisone for 4 days. Patient was not improving, so they came to RGCI for further management. On examination, she was hypoxic with SpO2 of around 82% on room air. She had bilateral coarse crepitations, all over the chest, and she was, rest of the physical examination was normal apart from mild splenomegaly. This was an X-ray which we got in our hospital. I don't have the X-ray which she presented to in the other hospital. As you can see, there are patchy infiltrates, diffusely scattered and like distributed in both the lung fields. Basic labs showed some. Obviously, she was an underlying CLL, so there was hyperleukocytosis with very few neutrophils. Otherwise, the labs were okay. LFT was okay. Peripheral smear showed these features of CLL only. So we made a working diagnosis of community-acquired pneumonia in a CLL host, which was not improving on empirical antibiotics given in the previous hospitalization. Since the immune defect in the CLL host is from the B cell arm, the possible pathogen generally in these patients are community-acquired viruses.
Dr. Nitin, please speak a little louder.
Okay, sir. Is it better, sir, now?
Yes.
So, since the immune defect in the CLL patient is a B cell arm, so the possible pathogens are community-acquired viruses, Streptococcus pneumonia, pneumococcus, atypical pathogens, and if the patient has been given some therapy for CLL, which may include eclampotine or some other therapy, then the patient will become prone to fungal infections like aspergillosis. So we conclude the patient on piptazo, we send the blood culture, we include a viral panel, we did a urine pneumococcus antigen and send a serum galactomannan. Streptococcus pneumococcus antigen came out to be negative. Galactomannan in the blood came out to be 1.91, which was positive. More than 1 was considered positive. We did a blood culture which later on came out to be negative, and the viral panel picked up influenza A. We did a CT scan also since the patient was hypoxic and she was not improving from the other hospital. So CT scan showed bilateral pulmonary consolidative GGO with some interseptal thickening and some lymphadenopathy, which was secondary to CLL person. This was the CT scan picture which you can see from the photograph. So final diagnosis of influenza A pneumonia with probably invasive aspergillosis was made. Antibiotics were stopped. She was started on oseltamivir and voriconazole was also started since she had serum galactomannan also positive. Patient remained in the hospital for around 2 weeks. It took a long time for her oxygen requirement to come down. She required a lot of chest rehabilitation, but she got discharged successfully. And she was given voriconazole for around 6 weeks in total. So lower respiratory. So this was just a case vignette in order to sensitize the viewers how viral infections can present. They need not all viral infections may not present with severe community-acquired pneumonia or ARDS kind of picture. Sometimes they can be slowly deteriorating patients also can present with viral infections. So respiratory tract infections are basically divided into two portions: upper respiratory tract infections and lower respiratory tract infections. I know this is very basic, but it is always good to revise some things. Infections acquired from infections localized to nasal cavity, pharynx, and larynx are known as URTI, which typically means rhinitis, sinusitis, pharyngitis, and sometimes and middle ear infections like otitis media. Whereas infections affecting the trachea, primary bronchi, and the lung parenchyma are known as LRTI, which can be further divided into bronchitis, tracheobronchitis, bronchiolitis, and pneumonia and its complications. So viruses can affect any of these pathways. They can cause URTI as well as LRTIs, and I am supposed to cover only LRTI in this lecture today. So what is the epidemiology? I will not go into epidemiology details from the Western countries because that is not pertinent to us since we are a nation with different population dynamics, with different population density. So Indian epidemiology matters to very much. So this is one of the largest amalgamation of papers of systematic meta-analysis or a review which was done and published recently, which basically looked into various papers published way back from 1960s to up to 2020s. They removed the cases of SARS-CoV because that is a separate pandemic altogether. But in general, the more common viral infections which happen in India are restricted to RZV, influenza A and B, and sometimes other viruses like PIV and human metapneumoviruses. These are the three top pathogens are RSV, influenza A and influenza B. These are the three pathogens, common respiratory viruses which they study throughout the country, and which is basically amalgamation of various case series or various reports of various authors published from various parts of the country, including South, North, East, and West. And as you can see from this slide as well, there was slight difference between what is more common in North India and other parts of the country. What is more common is in the dark blue. That basically means RSV. So RSV, influenza are the two more common pathogens. But other pathogens can also contribute depending upon the seasonality, and sometimes they can like recently for last 2-3 years we started to see adenovirus also causing a lot of these kinds of infections. But traditionally RSV and influenza A and B are the more common pathogens which are acquired, and there can be regional as well as seasonal variability depending upon the your area of practice which you need to know. Now, what are the risk factors for someone to develop a severe viral lower respiratory tract infection or severe ALRI. So this is a paper which was recently published and which showed that if the patient is of older age, patient is underweight or overweight, has a history of coronary artery disease and a past history of any chronic respiratory tract illness like COPD, bronchiectasis, etc., or a past history of pulmonary TB. These are the 3-4 risk factors which you need to look into it. And if these are present, that this patient may be at high risk of developing a severe respiratory viral infection. Other comorbidities like even malignancy or other, currently smoking, these are also important factors, but this is what they identified, that age more than 70, under and overweight, coronary artery disease, and past history of TB or chronic respiratory illnesses are the major risk factors for developing severe acute lower respiratory tract viral infections. So when should we test for all these viruses? Because virus testing comes with a cost also. So whether should we test for every patient, any patient who is coming with fever, cough to you, should he or she be tested for everyone? So these are the options. Should we test for every patient? Should we look for specific risk factors? Should we look for specific presentations? Or should we look for any specific radiology findings, and then only we should ask for virus testing? So I'll try to answer these questions a little bit. Specific presentations. Any patient presenting with acute onset respiratory symptoms getting admitted to the hospital should ideally be tested for viruses, because by symptomology point of view, it is very difficult to delineate whether this patient is having a viral infection or a bacterial infection in the lungs. So any pneumonia which is presenting to you, at least acute pneumonia or acute COPD, asthma exacerbation, should ideally be tested for viral infections, because in turn testing for viral infections reduces antibiotic usage, gets you an exact etiology why the patients got these symptoms, helps in managing these patients, prognosticating this patient, and also helps in, very importantly, hospital infection control. So one important history which we have been taught is to ask for the history of similar illness in the family members. If that is present, then definitely it should be a virus only. That is true, but it does not mean that if that is absent, that it can't be a virus. So yes, it is a very important history. If that is present, that means you can very well be sure that this illness in the patient itself should be viral only. But it cannot be used as a rule out point. That is, if that is history is absent, you cannot say that this is not a viral illness. This was also proven by many studies. One of the studies has been done from India. I was also part of the study, in which they found out that the history of sick contact was found in only close to 50% patients only, not in all the patients. And also, these similar findings were also proven by from other countries as well, in which they found that this kind of history or this kind of proven viral infections in other family members was found only 42% of the cases. So not necessarily that you will find a history of similar illness or history of sick contact in the family before you say that this is going to be 100% virus only. Coming to specific radiology findings. Now, there are traditionally in medicine, we have been taught to differentiate pneumonias into bacterial and viral pneumonias, looking into the X-ray or the CT scans of the patients. So let's look into this. Now, bacterial pneumonias can present with typical lobar pneumonias, which has dense homogeneous opacification, which is classically seen in bacterial pneumonias, and very, very rarely present in viral pneumonias, which extremely rare. But other presentations like bronchopneumonia, bronchiolitis patterns, these two patterns can still be present in bacterial pneumonias as well. So this picture cannot be used to rule out viral pneumonias. Viral pneumonias typically present with interstitial pattern, that is the most common. Interstitial pattern means diffuse, numerous GGOs accompanied by subtle reticulation lacking significant centrilobar nodules or consolidation. Rarely they can also present with bronchopneumonia pattern and bronchiolitis patterns. Lobar presentation is very rare in viral pneumonia. So specific radiological findings can help you guide towards whether it is a virus or a non-viral illness. So unless the patient is having a clear lobar pneumonia with other features strongly suggesting bacterial pathogen like neutrophil leukocytosis, do not depend on radiology to decide whether you should be testing the patient for viral pathogens or not. So any patient who is getting admitted in the hospital with acute onset respiratory symptoms and you have made a diagnosis of pneumonia needs to be tested for respiratory viral pathogens if the resources allow in your hospital. Now, should we be testing in the OP patients or not? So I believe if we are managing these patients as an outpatient basis, then the cost-effective analysis does not break even. So you can skip the virus testing, particularly if the virus testing is expensive. You are doing a syndromic analysis. But this is not a rule. There can be exceptions to this, particularly if you are dealing in an outbreak situation, like we all dealt with when we were dealing with COVID-19. COVID-19 was essentially a respiratory viral infection, and many patients came as an OPD. But because it was an outbreak situation, we tested those patients as well. And that can apply to anything. Like recently, now for the last week, we are again seeing surge of SARS-CoV-2 again in patients presenting with minor respiratory disease. Or some, as ma'am said, again we are seeing surge of influenza immediately as the monsoon has arrived. So in those situations, you can choose to test few patients to know what is going on with the company. Otherwise, in patients who are immunocompromised, like the patient which I presented, there can be chronic lingering symptoms, and particularly in those patients who are having CVID, who are having drug-induced hypogammaglobulinemia, or have underlying malignancies which affect the B cell arm, like multiple myeloma or CLL. They may not be admitted because the symptoms are mild, but these patients benefit from testing, even if they are in the OPD setting. Now, whether it is cost effective or not. So to understand this, I will demonstrate another case which I saw recently. This is a 50-year-old male with squamous cell carcinoma of the tongue who has been undergoing radiation therapy and CT chemotherapy. He presents to the ICU with severe pneumonia and he is currently on HICON mask. He has been given empirically meropenem, teicoplanin, and doxycycline for severe community-acquired pneumonia and not improving in the last 48 hours. This is his X-ray, which is showing diffuse infiltrates. There was an underlying right-sided opacity because of the malignancy itself, but the rest other opacities were new. So the basic labs were done. Basic lab showed normal TLC with mild neutrophilia. Procal was 0.8, borderline positive. KFT was normal. And LFT was also essentially normal. So will you ask for a multiplex viral panel which may cost tens of thousands of rupees in this patient? What are the arguments in favor of doing a multiplex viral panel in this patient? Yes, if it is positive, I will get a diagnosis. I can start an appropriate antiviral and I can stop or de-escalate antibiotic. What are the arguments against? It is very costly test. I have specific antivirals for only influenza and RSV, and for them only I can add a therapeutic agent. Rest for other viruses, there is generally no therapeutic agent. And I want de-escalate antibiotics in this patient anyway, so I will not be, that point is not valid for me. These are the two sides of argument which you commonly, either you will discuss with your colleagues or you will argue in your own mind whether I should do a test or not. What I prefer is doing the test. We did the test in this patient and it showed parainfluenza virus 4, which basically we do not have any specific antiviral available as of now to treat this virus. But what we did with this patient was we isolated the patient, helping in hospital infection control. We stopped the meropenem, teicoplanin, and doxycycline, which was going unnecessarily for this patient. Now, why we were able to stop this? Because we were able to get a diagnosis and convince the treating team as well as the intensive care unit that you don't need so much antibiotics for this patient. This patient is having a viral pneumonia, not a bacterial pneumonia. Although to keep things calm and to make peace for everyone, we still kept the patient on amoxicillin, which is not a correct way, but I think we cannot keep on fighting for a single thing. So instead of giving very high antibiotics, after proving that it's a viral pneumonia, we came down to a very simpler antibiotic, more simpler or lesser narrower spectrum antibiotic. So therapeutic efficacy of this syndromic viral panels is not just restricted to identifying a virus and then adding an antiviral, because you're going to add antivirals only in two cases, that is RSV and influenza. That also the benefit is not very clear. But it helps in de-escalation of antibiotics, hence reducing antibiotic use in AMR. And most importantly, helps in hospital infection control, which is mostly a non-talked about topic, which is quite common. Most of the patients actually acquire even viruses from the hospital. So truly speaking, they are not community-acquired viruses. They are actually healthcare-associated viruses because hospitals are hotspots for all these pathogens which is lingering on. So if you can isolate these patients to separate rooms, if it is possible in your hospital setting, then definitely this is also an important point in favor of doing this syndromic testing in your hospital. Now, whether it is cost-effective or not. So we did this study in cancer patients, and what we found that we were able to de-escalate antibiotics in about 57.8% of these patients, and because in some patients we could find bacterial co-infection was also diagnosed, and because we were able to de-escalate these patients, if you look into the cost of antibiotics which have been saved, so we actually saved patients some money rather than escalating their cost of care. So it actually turns the other way now. So if you do this test and it comes out to be positive, your season is, if you're having a season like this we are having right now, and you select your patient properly with a good clinical history and examination, then you can definitely, the probability of test coming out to be positive is high, and you can actually save the patient some cost rather than actually increasing their cost of care. Coming to specific antiviral agents. Now, as I said, For influenza A and B, there is an antiviral agent oseltamivir available. I think everybody must have used it, heard about it, and given it to their patients. It is most effective when started early, within 48 hours of symptom onset. Duration is around 5 to 7 days, can be prolonged for immunocompromised dose, and can be used as a prophylaxis also. Other antivirals for influenza A and B like zanamivir and velpatasvir are currently not available in India as of my knowledge. Now there are reports which show that this intervention by giving oseltamivir is also not very effective. Agreed, but this is what we have as of. Then the other viruses, respiratory syncytial virus, these are the top two pathogens. RSV virus, the options are ribavirin, which is supposed to be given by aerolized form, but oral and IV may be used as an alternative. I have used a lot of oral ribavirin in these kinds of patients, but believe me that the drug efficacy is not very good, and the study is also primarily so beneficial only in HSCT hosts, not for routine community or immunocompetent hosts. SARS-CoV-2, I will not go into detail. We know everybody is aware about it. Currently, most of these antivirals which have been listed may not be available in the market, so that is also it. For other viruses like parainfluenza virus, like we saw in our case, human metapneumovirus, measles, parvovirus, there is actually no specific antiviral which is available. You can choose to use some agent, but that is very questionable. For adenovirus, 2-3 years back, there was a lot of community-acquired adenovirus, particularly in children, which was going on and leading to severe illnesses. You can use cidofovir, but again, the benefit or the evidence is primarily seen in immunocompromised source, limited to HSCT patients only. What are the complications of viral pneumonia? The most common complications are secondary infections, secondary bacterial infections particularly, which includes pneumococcus, pneumophilus influenzae, and staph aureus. And the other deadly problem which can happen with these patients, particularly those suffering from influenza pneumonia, is having a secondary mold infection, particularly aspergillus. Other extrapulmonary complications like immune-mediated hemolytic anemia, thrombocytopenia, Guillain-Barré syndrome, rash, encephalitis, myocarditis is again, myocarditis specifically is not very uncommon, but other things are relatively uncommon in this patient. Now coming to atypical pneumonia. So what is the meaning of the term atypical? The term atypical pneumonia was originally coined decades ago to describe pneumonia with an unusual clinical presentation and no identified specific causative agent. This is a very old definition. Later in radiological literature, atypical pneumonia was referred to as unusual radiological picture which could not fit into something or the other, like not a typical lobar pattern, so it was labeled as atypical pneumonia. We, as a clinician, when I learned atypical pneumonia was basically meant that the X-ray picture is bad, the patient is relatively okay, so it was not fitting into the clinical picture. That is what was taught to me. So, but this, what I could get from the literature, atypical word is very dubiously used, very loosely used in various parts of the literature. So better to avoid these kinds of terminology, but we still keep on using it because of the routine medical jargon which we commonly use in our day-to-day practice. So just a brief case upon atypical pneumonia. We had an 80-year-old male with diabetes with follicular lymphoma which received rituximab and bendamustine, and he presented to us with fever and cough for 10 days, was given amoxicillin and azithromycin for 4 days in a private hospital prior to coming to us. His systemic examination was unremarkable. His X-ray also looked quite okay to me. It was normal. But when we did a CT, because he was having persistent symptoms and he was not responding to antibiotic, we found that there was a retrocardiac shadow, retrocardiac GGO, and a small consolidation as well. We did a bronchoscopy with valve which showed mycoplasma pneumonia. He was given doxycycline therapy for around 7 days. Now, why did this patient develop mycoplasma pneumonia infection? You can always ask, when should we suspect this pathogen? And when should we cover atypical pathogens in LRTA? Now, this is a very old paper from NEGM which looked into the pathogens of the community-acquired pneumonia. One of the, this is from US, 2015 paper. So one of the ironical finding in this paper is that they were able to identify pathogen in very few percentage of patients. So not every percentage of patients are going to identify a pathogen in pneumonia. That is something which we need to keep into mind when we are dealing with patients like of community-acquired pneumonia. So in this also the atypical pneumonia was just seen in, like mycoplasma pneumonia was just seen in 0.5% of the patients, whereas Legionella was seen in 0.4% of the patients. These are the 2-3 top atypical pathogens which are labeled for pneumonia. This paper looked into the epidemiology, characteristics and treatment outcomes of patients with mycoplasma pneumonia in adult patients, and they recruited in total around 747 patients. And this paper actually looked into what is the prevalence of atypical pathogens in pneumonia. So they found that the overall prevalence is around 8.1%. And in severe pneumonias, then it is the top 3 pathogens are chlamydia, mycoplasma, and Legionella, which ranges from 1.8% 2.8% for mycoplasma and 4% for Legionella. This is a meta-analysis from all over the world, not pertaining to any specific area of the world. Right? So we don't have a high-end epidemiological data from India regarding atypical pathogens. So when should we suspect this pathogen? Short answer is there is no clinical or radiological feature which can predict this pathogen. So ideally we should be suspecting this pathogen in all the patients who are presenting with community acquired pneumonia. Now this is to prove what I am trying to say. None of the patient history, examination findings, lab findings actually point out whether these patients can have atypical pathogens or have non-atypical pathogens. Any typical radiological features can be also because of mycoplasma pneumonia or any other atypical pathogens like Pneumonia or Immunizations. So, in order to prove that this is atypical pneumonia, we need to do a PCR test, which is generally done in a respiratory sample. Serologies can also be done, but they will give a probable diagnosis. Legionella antigen test is also available in India, but it is quite expensive and it suffers from poor sensitivity, but it has very good specificity.
Please be a little louder.
Sir, I think
I'm.
Okay, sir. So I think anyway, I'm just finishing off, sir. My last 2 slides only, sir. So atypical pathogens can also have complications which we saw in the viral things, which includes immune-mediated hemolytic anemia, thrombocytopenia, Guillain-Barré syndrome, rash, encephalitis, and myocarditis. When should we cover for this? In all the guidelines which you know from pneumonia point of view, all the guidelines actually ask us to cover give macrolides or respiratory granules in admitted patients. So, and one of the reasons is to cover these atypical pathogens. The other reason for macrolide adding is to have an immunomodulatory action. Targeted therapy can be done once you have isolated the pathogen, once you prove that it is this atypical pathogen. One point to remember about mycoplasma is that we have very high incidence of macrolide resistance in mycoplasma. So macrolide generally don't work for mycoplasma in India. We have to switch to other therapies like doxycycline in these patients. So prevention from viruses and atypical pathogens basically depend on education of the patient, which is very important. Respiratory hygiene, ventilation of rooms and buildings. We are now living in air conditions rooms and environments, so that if the incidence of all these pathogens are increasing. Prevent overcrowding, vaccination which Dr. Jatin will take in great detail, and obviously hand hygiene. My take-home message is suspect and test for atypical and viral pathogens as and when appropriate in these patients. Practice de-escalation of antibiotics if you have identified virus and atypical pathogens, which is of great importance and makes your test cost effective. Educate patients and colleagues about prevention, which includes vaccination, which Dr. Jatin will take care. Thank you.
Thank you, Dr. Nitin, for an excellent talk. And I think rightly said is that we have to be very, very careful in choosing the diagnostic panel for viral pneumonias because the cost which is associated with it. But nevertheless, the 4 pathogens which are very, very important, that is influenza, A, B, RSV and COVID, at least those 3 multiplexing PCRs can be looked into, and those assays should be there available even for hospitalizers. And important thing that you have said is the de-escalation of antibiotic or empirical use of antibiotic once a confirmed diagnosis of viral pneumonia has been established. That needs to be taught to the physicians that should, and another is how long the antibiotic, like whether you want to stick on to the 5-day rule or just 3-day, if there is no underlying comorbidity and it's a clean viral pneumonia. So these are questions apart from the, I think we will take up questions once the second talk is also completed. And another important thing is regarding the immunization or vaccination, especially as a preventive aspect to protect us from these pneumonias. So this is again an important learning topic, whom should vaccinate and what should be the timing for these vaccinations should we take? Should be very elderly or children should take up? Are they adult immunization practices now are available or not? So we have Dr. Jatin Ahuja. Sir is a consultant of infectious diseases at Indraprastha Apollo Hospital. He is trained into transplant infectious diseases from Toronto. Extensive experience in internal medicine, certified echocardiographer, endoscopy and colonoscopy. He has received certificates and also certifications for travel medicine specialist and in adult and immunocompromised vaccination, for which this talk is about, is a core member of Antimicrobial Stewardship Committee, Infection Control Team at Indraprastha Apollo, New Delhi, and is a contributor in antimicrobial guidelines and policy at, along with AIMS New Delhi. He's academic and innovation founder of Infections.com, which is infectious disease platform, and his areas of interest are in transplant infectious disease, antimicrobial stewardship, and vaccination. So over to you, Dr. Jatin. Welcome, and I think it's an interesting topic regarding the immunization practices.
Very good evening, everyone. I hope I am audible. Thank you,
Yes, yes,
Dr.
yeah.
Ekta. Thank you very much for giving me the brief introduction. I would like to thank Dr. Chawla and Dr. Kancha Chawla also for setting up this stage, and Dr. Nitin, who has already summarized the lungs has been seized by so many of pathogens. Uh, we have only pair of lung and been seized by so many of pathogens, which has been on daily basis. We come across in our rounds and seeing so many pathogens attacking our lungs. How could we prevent it? This is what all the today's topic is. I would also like to thank the entire
नोज एंड
NCCP
नेजल पॉलिप है
society who has given me the opportunity
कि
for
उसको दवा
presenting
से
the
ठीक
topic.
कर दो तो वो दवा से जाएगा ही नहीं, वो जिंदगी में नहीं जाएगा दवा से, ऑपरेशन करना पड़ेगा। और मेरा छोटे बच्चे को ऑपरेशन भी नहीं कर सकते।
Are my slides visible?
Not yet, sir.
Is it visible now?
No, we can only see your screen.
I think it will come. Yes, it is there.
Yeah, we can. No,
We were able to see.
we can see now.
Make it a full screen. I think.
Is it visible now?
Yeah, it's visible.
जब वो वहाँ से निकल के
Speak little louder.
वो एक टाइम क्या रहता है, ऐसा डालते हैं ना, वो ऐसे चला जाता है।
Start my topic. Today's topic is immunization strategies for prevention of severe respiratory infections. So whenever the term immunization comes into the mind, it always vaccine automatically comes into the picture. But immunization doesn't always mean it is the vaccination. Immunization means it is the protection against that particular pathogen. So immunization is not equivalent to vaccination. So immunization can be acquired by the initial previous insult by that pathogen also, and automatically developing the antibody or T cell immune response of our own body, leading to the protection. That is also known as immunization. So it is the protection overall against the pathogen, which is known as the immunization. So protecting the older and chronically ill lung. This is what our objective is, especially the chronic respiratory diseases, where a lot of patients are having the n number of bugs on and off. Also the immunocompromised populations. This is what we are going to discuss in the subsequent slide. What are the vaccines available in our armamentarium and how we gonna give it and how we can timeline it. What are the patients who can get benefit? This is what we are going to discuss.
ಅವನು ಹೇಳ್ತಾರೆ ಬೇರೆ ಡಾಕ್ಟರ್ ಬಂದಿದ್ದಾನೆ ಅಂತ.
ಏನಾಯ್ತು?
ಅವನಿಗೇನಿಲ್ಲ, ನನಗೆ ಈ ಫಿಂಗರ್ ಇದೆಯಲ್ಲ, ಈ ಫಿಂಗರ್ ಸ್ವಲ್ಪ ನೋವುತ್ತಿದೆ.
I think you share again.
ಏನಿಲ್ಲ, ಸುಮ್ಮನೆ
Your presentation.
Yeah, is it coming? Yeah, I think it's
No,
going
no,
on. Not coming.
no.
ಈ ಪಾರ್ಟ್ ನೋಡೋದು.
Share the screen.
ಆಕ್ಚುಲಿ ಇದು 1 ಮಂತ್ ಇಂದ ಅಷ್ಟೊಂದು ನೋಡ್ಲಿಲ್ಲ, ಈ ರೀಸೆಂಟ್ ಆಗಿ ಜಾಸ್ತಿ ನೋಡುತ್ತೆ.
ಈಗ ನರ ಸ್ವಲ್ಪ ಪ್ರೆಷರೈಸ್ ಆಗಿದೆ ನೋಡಿ.
ಅದೇ ನಾನು ಅನ್ಕೊಂಡೆ ನರ್ವ್ ಸ್ವಲ್ಪ ಇದಾಗಿದೆ. ಅದೇನು ನೋಡ ಬೆಲ್.
Is it?
Yeah.
Yes.
ಇದು ಒಂದು ಸ್ವಲ್ಪ ಮೆಡಿಸಿನ್ ಆಯಿಂಟ್ಮೆಂಟ್ ಕೊಡ್ತೀನಿ ಅದು
So
ಹಾಕಿ.
there's my conflict of interest. No pharmaceutical company endorsement or sponsorship is there. Only a science-based discussion is there.
ಮತ್ತೆ ನಾನು ಬಟ್ಟೆ ಹೋಗ್ಬೇಕಂತ ಹೆಂಗ್ ಮಾಡೋದು?
ವಾಷಿಂಗ್ ಮಷೀನ್ದಲ್ಲಿ ಮಾಡೋದು
Sir, it's calling trouble.
ಹೊಸ ಅದು
It is not
automatic
moving.
machine ಬರುತ್ತಲ್ಲ
No, sir, it's not.
ಬಕೆಟ್
I think move it up and down.
ಬಕೆಟ್ ಇದೊಂದು ಇಲ್ಲ
ಅದೇ ಇದೇನೋ
Yes, no, it is moving.
Yes.
ಈ ನರ ಇದೆ ನೋಡಿ ಇದು ಒಂದೇ ನರ
So, what are the learning objectives? Sorry for the trouble. So, there are 5 learning objectives we are going to see in the sequence next 20-25 minutes. First is the justifying adult respiratory immunization being using burden, immunosenescence, and the comorbidities. How we can justify the vaccination whenever we are going to prescribe it in our daily prescription. Select the correct pneumococcal and influenza strategy for given adult, because we know a lot of pneumococcal vaccines are available. A lot of influenza vaccines are also there. Dosing are also variable. So,
ಜಾಸ್ತಿ ಖಾರ ತಿನ್ಬೇಡ
whom to given what, this is what our main goal is. Appraise the emerging RSV vaccine, pertussis, COVID-19, and the HIP evidence. Do we have to give each vaccine to every individual? Tailor the vaccination for especially the chronic respiratory diseases like COPD, asthma, and the immunocompromised and the elderly population.
ಬಯಲ್ಬೇಡ
And implement immunization in routine chest practice or routine, I would say, clinical practice, screen, recommend, as well as the co-administration, when we can co-administer various types of vaccination.
ಏಜ್
So, as this global burden of data from the Lancet journal,
ಚೆನ್ನಾಗಿ
which
ಕೊಡಿ.
says that 2.5 million deaths each year from the lower respiratory tract infection worldwide, and it's the leading cause of death globally. Pneumonia after the I would say respiratory pathogen infection is the leading cause of death, and it's 5 times higher pneumonia risk in the adults who have the chronic respiratory diseases
ನಿಮಗೆ
or
ಬೇಕಾದ ನೋಡಿ ಈ
underlying
ಕಡೆ ಬನ್ನಿ
cardiac problem or as compared to the healthy peer group of the same age group. So, a lung under siege, always living in the daily fear. As Dr. Nitin has mentioned correctly, a lot of pathogens are attacking the lungs on daily basis, like bacteria, mycobacteria like antium, mycobacterium tuberculosis, viruses. A lot of viruses are there, and of course fungus, which are ubiquitous in nature. Patient lives under daily threat. We cannot vaccinate every enemy, but however, there are few enemies who are makes the lung vulnerable, more lead to exacerbation. So we need to vaccinate at least those pathogens which vaccines are available. So there are vaccine preventable diseases which we are going to discuss. So what is a vaccine and how does it protect? So vaccine safely prevents the immune system with a pathogen or its key antigen, which helps in training our adaptive immunity. Adaptive means whenever the either the live antigen or it is the attenuated antigen introduced in our body that leads to the development of the antibody immune response. And it may also help in the memory boosting whenever the pathogen next time enters in our body. So antigen once delivered, vaccine presents a harmless antigen to the APCs, that is the antigen presentation cells, which helps T cells to stimulate the B cells. And B cells are the responsible for production of the antibodies and long-lived memory B and T cell stimulation. So whenever there is a new pathogen which has already been vaccinated in the past or already had it by a natural infection, there is a rapid surge of the antibody response that leads to the neutralization of the pathogen.
ಇದು ಹಂಗೆ ಹಚ್ಚಿ ಮಸಾಜ್ ಮಾಡಬೇಡ
Already, if we talk about the UIP, that is Universal Immunization Program of India, we have already covered 85% of childhood population. However, if we compare with the adult, look at the adult influenza vaccine uptake, it's hardly 2%. Same with the pneumococcal vaccine. What's the reason? Because there is no, I would say, government initiative for influenza or pneumococcal vaccination, and it's individualized based on the underlying diseases, based on the definitely the cost, because a lot of have to be taken from the pocket. So influenza and pneumococcal vaccine in adults is really, I would say, marginally lacking as compared to the childhood UIP coverage. Where we are headed. So why vaccinate adults? The question comes, why should we vaccinate them? Why should we spend a money of around 4,000 or 5,000? The patient who is having the just a chronic respiratory disease, already he's been bombarded by the financial things because of the underlying disease. Should we also ask them to go for the influenza or pneumococcal vaccine? And what pneumococcal vaccine to be chosen? if influenza, what vaccine, whether it's a standard dose vaccine or it's enhanced vaccine. Then comes the RSV, pertussis, and COVID HIV vaccine. They are the other adjuvant vaccines which may be needed depending upon the underlying host status. Then comes the special population that depends upon the underlying, I would say, respiratory problem or underlying systemic problem. And then last, we're going to see the co-administration practices, which we should be practicing in our routine day-to-day practice, and two clinical cases, one for the pneumococcal, another for the influenza, before we go take for the take-home message. Why the aging lung needs protection? So there are the three things which are the most important. One is the immunosenescence. Fewer naive T cells and weaker B cell responses. As we grow older, the naive T cells are get on the lower side and our antibody response becomes on the downside. That is why the immunosenescence leads to the poor antibody response. That also, whenever the patient has the previous infection, the antibody response becomes weaker with the growing age. Inflammaging. Patients who are having the chronic respiratory diseases, who are already having the autoimmune diseases, they have the baseline inflammaging, and that also leads to the poor outcomes and poor antibody response. Then comorbidities. It could be anything. It could be generalized. It could be specific organ based. So clinical consequences depend upon the what kind of vaccine we can give, whether it's a polysaccharide vaccine or conjugate vaccine. To overview, polysaccharide vaccines, they are cheaper, and number one, number two, they don't mount the mucosal immunity, and they are T cell independent. That is why the vaccine immunity lasts for the shorter duration. However, the conjugate vaccines, they are T cell dependent. They mount the prolonged response, and there are also mucosal antibody response also there, and they are definitely are faster than as compared to the polysaccharide vaccines. So, in this today's talk, we are going to see the 5 vaccine preventable threats mainly, and the last definitely the hip vaccine. So, pneumococcal, commonest cause of bacterial community acquired pneumonia and invasive disease. That is our top adult target. Influenza, annual epidemics, seasonal triggers for the COPD and the cardiac event precipitation. RSV, newly preventable in older adults and via maternal dose, especially indicated in the, I would say, Western world. We don't have the vaccine as of now. Pertussis, it's a resurging. The adult Tdap booster also protects against the newborn through the mother vaccination. And SARS-CoV-2, we all know that in the recent pandemic, we all have been vaccinated also, as well as the natural immunity have been boosted up after the natural infection. So a single pair of lung and attacked by the 5 to 6 common pathogens, the flu, the pneumo, RSV, COVID, and the pertussis. It's a repeated respiratory infection, severe exacerbation, and the lung function declined with each and every attack. But what next? The recurrent hospital admission, the recurrent burden on the family, and moreover, from the science perspective or ID perspective point of view, it's a broad spectrum antibiotic used every time. On an average, if 2 to 3 admission per year, it will lead to the AMR, that is the antimicrobial resistance. Because every time patient comes to the emergency, we need to start with the beta-lactam along with the atypical coverage, because we don't know in the initial settings whether we are targeting the viral pathogen or we are targeting the bacterial pathogen. So, what are the 6 vaccines we want to give? Who are the candidates? What to be given and when to be given? Influenza is the first one. Everyone who is more than 6 months of age strongly indicated, especially in the elderly and the underlying chronic lung disease. What to be given? Annual vaccine, we know it's the standard dosing vaccine is there, and if the age is more than 65, definitely should be received every yearly. That is pre-monsoon. And when to be given? That is already I told it's pre-monsoon is the best time to be given. That is southern hemisphere strain. Why which strains to be selected? We'll see in the subsequent slide also. COVID-19, older and higher risks are the person who are more prone to get the COVID-related problems, ARDS. What to be given? Updated booster. But unfortunately, in our country, we don't have booster right now. If we ask patient to take the booster dose, especially if they had the not taken the vaccine in the past COVID, or patient who is having the recurrent bouts of the COVID and I would say exacerbation of the lungs, still patient doesn't have the COVID vaccination. That is a matter of concern. We have already seen the recent surge of the COVID cases in Andhra Pradesh and surrounding states, but there is no vaccination as of now. When any time per current national guidance, depending upon the patient's epidemics going on, because now we can't say pandemic going on, it's the epidemics. The local endemicity pockets might be there, which requires the updated booster dosing. RSV, all the adults more than 75 years of age, irrespective of the underlying comorbidities. 60 to 74 who are already had some risk. And in pregnant females, definitely to be given if, especially at the, I would say, third trimester to prevent the infant who can get the RSV related complications. What to be given? Single dose. A maternal dose protects the baby also. And when to be given? Before RSV season, especially in the winter surge. Most common reason for the bronchiolitis and bronchopneumonia in the childhood is the RSV. So we need to protect our childhood population also. Pneumococcal, adults more than 50 years. Earlier in the ACIP, that is Advisory Committee of Immunization Practices in the US, they mentioned about 65. Now the age group is more than 50 years. Why so? Because the invasive pneumococcal disease, community-acquired pneumonia, after the 50, it has surges to more than 4 times. So the right time is 50 plus, not the 65 plus. This is what the major change is. The same has been copied from the Western world to the Indian guideline also, whether it's an Indian Chest Society or whether it's an other guidelines of the which India follows. So it's a single PCV20 which is available in India right now, which should be given. And nowadays there is no confusion, single conjugate vaccine can be given. PCV15 or 13 followed by the PPSV, that is polysaccharide 23, was the initial way. When less than 65-year gentleman comes, we need to target with the PCV13 followed by the polysaccharide vaccine after a year. When to be given? At the diagnosis only. When the patient comes of COPD or asthma, once gets stabilized, should be vaccinated. Same with the CKD, at the time of diagnosis also. Pertussis, all adults at least should receive the single dose of Tdap. This Tdap is different from the DPT which is given in the adults. The only difference lies in the less antigenicity of D and P, not the T. T always remains same whether you take the Tdap or DPT. Tdap, one adult dose. Ideally, it should be repeated after the every 10 yearly. When to be given? All pregnant females at the third trimester is the right choice. Hip. So this is what the good catch is. In the hip vaccine are not indicated in the chronic respiratory diseases. They are only indicated if there is asthenia, sickle cell disease, complement deficiency, HIV or hematopoietic stem cell transplantation. It's a single dose vaccine is there, and 3 doses are indicated only in the autologous hematopoietic stem cell transplantation or post HSCT, whether it's allogenic also, but at least after 6 months of the post transplantation. Since it's a I would say inactivated vaccine, it can be given after 6 months of the post HSCT. It is not indicated for routine COPD and asthma patient. That is what the main point is. It's not a main vaccine, but rest of the 5 vaccines are the main vaccine to be vaccinated for all the patients who are having the chronic respiratory diseases. Coming on to the structure of the influenza, we know there is a attachment particles which is known as antigen, HA, hemagglutination, that is the main antigen. Another is the enzyme releasing, that is the neuraminidase segment. And there are 8 RNA segments which is present inside the envelope. How the vaccine is been cultured or grown? It is either egg-based, cell-based or recombinant-based. In India, we only have the egg-based vaccine, whether it's a split virion or it's a subunit vaccine. If we talk about the split virion vaccine, it is mainly the I'll give you the example, Vaxiflu. Vaxiflu is a split virion vaccine where all the components of the vaccine, or I would say the virus, it gets separated by the use of a beta propionolactone, and the antigen part is been used for the development of the vaccine. However, for the subunit vaccine, there is another technique which is known as formaldehyde neutralization of the antigen. Then it is to be used for the example is Influvac tetra, which is the Abbott vaccine. So both vaccines are being used on a, I would say, daily basis, but the way of, I would say, the manufacturing is both are different. We have the dosing 0.5 ml intramuscular deltoid annually, that is pre-monsoon. Live vaccine is to be given intranasal 0.1 ml over each nostril, and especially it is given in the less than 49 years of age, the live influenza vaccine. Those who have the might be egg allergy. High dose influenza vaccine whom to be given? It is all the adults who are 65 years of age. Unfortunately, we don't have the high dose vaccine. So sometimes if we have to give our patient, like in CKD, we give the hepatitis B vaccine in a double dose. Similarly, each standard influenza vaccine having the 15 microgram of the hemagglutinin antigen. But however, the high dose contains 4 times higher. If we cannot give the 4 vaccine to the individual, we are giving the either the single vaccine, standard vaccine as per the recommendation from the Indian guideline, or if the patient is having the marked immunocompromised, 2 vaccine shot can be given. So all adults more than 6 months of age are the candidates. Underlying chronic respiratory diseases, elderly, pregnancy, and any comorbidities. And definitely all the healthcare workers or caregivers who are in the hospital practices. Contraindications and cautions. The GB syndrome within the 6 weeks of prior influenza dose is complete contraindication. And live attenuated influenza vaccine is definitely to be avoided in the immunocompromised status and severe asthmatic patient and pregnancy. Coming on to the pneumococcus, we know that Streptococcus pneumococcus is a polysaccharide gram-positive diplococcus, and the various serotypes are coming because of the 100 capsules, different types of capsules are there. That is why we have a different types of the pneumococcal vaccine, whether it's to be combined with the CRM 197 to make it a conjugate vaccine, or without the CRM 197. What does CRM 197 indicates while making the conjugate vaccine? So CRM 197, it's a, I would say, non-diphtheria antigen and non-toxic. It's a diphtheria antigen which is non-toxic. It is combined with the polysaccharide capsule that leads to the development of a conjugate vaccine. As I earlier mentioned, conjugate vaccines are being used for making the robust immune response. Robust immune response, memory cells are stimulated. That is why the immunity lasts for longer time. So there are the different types of the pneumococcal vaccine. We have recently in India Prevnar 20, which we are giving it on a routine basis. The single dosing is required. Now there is no confusion. All adults more than 50 years of age, underlying definitely respiratory diseases has to be there, or what are the contraindications? So severe allergy to prior dose to the diphtheria toxide. I mentioned the conjugate is of CRM 197. If the diphtheria toxide is causing allergy, should be avoided. In that condition, polysaccharide can be given. Therefore, for moderate to severe acute illness also. So in a patient who is already acutely ill, should be avoided. Coming on to the SARS-CoV-2, we all know the structure of the SARS-CoV-2. We have learned so many times in the last couple of years. It's a spike protein, which is the main target antigen, then membrane, envelope. So what are the types of vaccine which can be made? The mRNA vaccine, we know the Moderna vaccine was there, the Pfizer vaccine, protein subunit vaccines were there, which is the adjuvant vaccine. And then the viral vector vaccine, which is the COVID shield type vaccine, which makes the spike gene replicate into the non-replicating adenovirus to stimulate to our T cells. There are different types of platforms which have been used to make the COVID vaccine. The dose is again 0.5 ml intramuscular. Initially, the 2 doses are recommended, and later on, we know that the 3rd booster dose already we have received. However, the patients who are older and high-risk adults, they are still the candidate of receiving another booster dose. But unfortunately, as I mentioned, we don't have as of now, the booster dose to vaccinate our older population, because we know the SARS-CoV-2 virus have a tendency to mutate. Recently, the Omicron subvariant, which has been there, is already been mutated, and we don't have the immunity with that kind of virus. What are the contraindications? Severe anaphylaxis, prior myocarditis or pericarditis, even the prior stroke also should, in that condition also, it should be avoided. It is safe to co-admission with the influenza vaccine. We know the COVID vaccine can be admission along with the influenza vaccine. There is no harm. The virus and how its vaccine is made. So as we know that the RSV, the respiratory syncytial virus, it has the 10, it's in, first of all, it's a negative RNA virus. Number one, it's an enveloped virus. And number three, it has a fusion protein. And the fusion protein is of two types, pre-fusion form and the post-fusion form. Whenever the vaccine is being trying to made, we use the pre-fusion protein in the RSV. It's the stabilized pre-fusion protein, or it could be protein subunit, and it could be mRNA vaccine. So already the Western world has the three types of vaccine. One is from the either a antigen, single antigen vaccine, or it could be a dual, or that is from the Pfizer company, and it could be from the mRNA vaccine also. RSV again, it's a 0.5 ml intramuscular single dosing is there. As I mentioned, RXV, like you can see on the screen, protein subunit pre-fusion protein. RXV is from GSK. It's a single subunit vaccine. Abrysvio is from the dual antigen vaccine. And adjuvanted and non-adjuvanted formats are also there. And the mRNA vaccine, which is the mRESVIA, it's also the newer type of vaccine which is available. What the candidates I already discussed in the recent slides. What are the contraindications? Severe allergy to a prior dose, protein subunit only. So in the third trimester, it can be given. But however, if the patient has the allergy in the past, or if you're trying to give the non-adjuvanted vaccine, it should be avoided in the pregnant state. We don't have this vaccine in India right now. However, we have certain antibodies which can be given in the childhood state, especially in the neonate, to prevent going into the bronchiolitis or bronchopneumonia. The fifth one, that is the pertussis, the organism, how its vaccine is being made. The pertussis, it consists of 4 antigens. The pertussis toxin, which is the major one, FHA, fibrohemagglutination, pertectin, and the fimbre. The TD versus Tdap, there are 2 types of vaccines which are available. However, the Tdap, which is our main thing to be given after at least every 10 yearly for the prevention of the bronchopneumonia. The problem with the pertussis is after every 3 to 5 years, the immunity of the pertussis goes away. That is why the recommendation is after every 10 years, Tdap should be repeated. So again, the dose is 0.5 ml intramuscular. It comes with the Boostrix as well as Adacel. The benefit of Boostrix is it can be given after the 65 years of age also. However, the Adacel is recommended less than 65 years of age. Indication, all adults, at least 1 Tdap should be given every pregnancy in the 3rd trimester. Contacts of infants also, like if the small child is there who cannot receive the pertussis vaccine, less than 6 weeks of age. In that condition also, the cocooning concept comes. That is to vaccinate the adults who might carry the pertussis and give it to the less than 6 weeks of child. What is the contraindication? So encephalopathy in the past, within 7 days of using the pertussis dose, is a complete contraindication. Allergy in the past and GB syndrome within 6 weeks of getting the pertussis vaccine or Tdap. So pneumococcal disease, the serotypes, the moderate conjugate toolkit, and how we can get vaccinated, we all have learned. They are the 5 types of the pneumococcal vaccine. When to be given, we know in the pediatric group PCV13 is there, and in the adult PCV20 is now the single choice. Coming on to the morbidity and mortality across the disease spectrum. So pneumonia, in the case fatality, if you talk about the pneumonia, less than 5%. However, if you look at the IPD, that is invasive pneumococcal disease, with meningitis, it is rising more than 20%. So the risk of getting the invasive pneumococcal disease is quite high. And each year, 1.2 million people are losing their life just because of the pneumococcal. If you talk about the Indian scenario, it is the largest absolute pneumococcal mortality burden. So we need to boost up our vaccination, especially with the pneumococcal. We have already learned that less than 2% uptake is there for the pneumococcal vaccine. If we look at the Western world, it is already having the good protection. However, there is the ongoing serotype replacement. We know that 23 serotypes have been covered by the polysaccharide and 2021 is covered by the conjugate. Now, from 2020 plus onwards, the other 80 serotypes are getting into the picture. Might be we see in the future other types of the higher valency pneumococcal vaccine.
फिर सुबह निकलना
This is what we have learned so far. The 4 to 5 vaccines, how we can give.
ठीक
India we
है,
have
एक जगह पर
PCP20,
जाकर बैठ के
PC15 is
ऐसे
not
तो
available,
शाम को
PC13 is there, and PPSP23
और
is there.
जितना चलेगा उतना बंद करेगा।
Coming on to the major, I would say, landmark trial, that is the capital trial, community-acquired pneumonia immunization trial of adults. In this, 85,000 adults have been studied in more than 65 years of age. It shows that vaccine type pneumonia prevention in 45.6%. However, if you talk about the IPD prevention or efficacy, it's 75%. Look at the benefit of receiving the conjugate vaccine. It's one of the landmark trials published in the NEGM in 2015.
तो अगर थोड़ा है, अगर wear and tear है तो वो ज़्यादा हो जाएगा।
Advisory Committee on Immunization Practice, I already mentioned, has lowered the threshold to 50 because the risk of getting the infection becomes 4 times higher as we cross the 50 plus year landmark. So at the 50 plus, we need to vaccinate our adults. Same has been adopted by the API and the ICH, that is Indian Chest Society also. What is the strong recommendation are COPD patient, bronchiectasis, diabetes, chronic heart, kidney and liver disease, and asthenia and the immunocompromised. All adults more than 65, but if we vaccinate at the age of 50, that would be the best. Use a conjugate vaccine first, no confusion. Now, vaccinate at diagnosis of COPD, not at the next exhibition. This is what the take home is. Pair pneumococcal with the annual influenza vaccine because patient will not going to give time for the next time. At the same setting, you have to vaccinate both pneumococcal as well as the influenza also. Coming on to the 68-year-old man, clinical case scenario, COPD on triple inhaler therapy, Gold 3, ex-smoker, 45 years, 2 exhibition in the past 2 years, and is already on the LAMA, LAMA and the real corticosteroids. Never received any pneumococcal vaccine. Out of 4 options, is the best option for him. He is 68-year-old gentleman. The best option is to vaccinate him with the conjugate vaccine, a single shot PCV20. If it is not available, he can vaccinate with the PCV15 or 13 available, followed by the after 1 year PPSV 23. Coming on to the influenza mortality, when to vaccinate. So it is the pre-monsoon and the southern hemisphere strain which is to be given. Nowadays, all the WHO in the last 6 years, if you look at the WHO data, the Yamagata strain is totally been vanished. These days, trivalent vaccine is being recommended instead of the quadrivalent vaccine. So these days, companies are also making the trivalent vaccine. First, there is no use of giving the Yamagata strain. Second, there is also cost difference. Now the cost has reduced to almost less than 40% after the Yamagata strain has been removed. As far as the Indian scenario is concerned, the southern hemisphere is the most common strain which is to be targeted. However, there are few parts of the India, like few part of Tamil Nadu and few part of the J&K, which commonly get the northern hemisphere strain also. And sometimes the migratory population from Western world, they also keep getting the northern hemisphere virus and keep spreading to the Indian setting. The influenza morbidity and mortality, people are getting the adult influenza-like illness, which are less in number, especially with the flu exposure. However, the hospitalization has markedly increased once the patient passes 65 years of age, along with the underlying comorbidity like diabetes or any heart disease. COPD exhibition definitely markedly increased. Along with that, any MI or strokes, almost 6 times higher within the week is been seen. This is the famous, again the paper been quoted from the Lancet 2018, which shows 2.9 lakhs to 6.5 lakh seasonal influenza respiratory death seen in the worldwide in the paper published Lancet. If you look at the Indian scenario, as I mentioned, the largest share is the Southern Asian flu. Each year, the WHO give the recommendation with which A strain and which B strain has to be taken and when to be taken and for especially for the Asian countries as well as for the Western countries. Influenza also, the vaccine uptake is less than 5%. Definitely, it's almost double than the pneumococcal vaccine because of the cost. It's cheaper than the pneumococcal vaccine, but still it is quite less if we talk about the gross scenario. Choosing the influenza vaccine. As of now, we talk about only the standard dose inactivated influenza vaccine. It is the egg-based vaccine, it's egg-based culture vaccine, and it is always the inactivated vaccine, which is containing the 15 microgram of the hemagglutinin antigen per strain. High dose contains 60 microgram. Adjuvanted, we don't have it, and recombinant also, we don't have it right now. Coming on to the enhanced vaccine protection, older adults better. Like if we see, like this is also a trial which is from the NHM 2014, which shows that 24% more efficacious of in adults who are 65 years of age getting the high dose vaccine of the flu, that is Fluzone HD. However, because of the lack of availability, we are still going with the standard dose vaccine. At least we should be going by standard dose of all the individuals of 6 months of age above. 1 dose a year is the current recommendation. Adults more than 65 years, if you talk about the ACIP, they recommend high dose. Indian practice, all high risk adults should be getting it. Time it to the local seasonality like pre-monsoon. Again, a case scenario from the influenza vaccine. We have a 72-year-old woman, diabetes and chronic kidney disease, and wants the flu shot now because it's a pre-monsoon going on. Which shot we are going to recommend? So ideally,
I request you to wind up.
yes, yes, ma'am. The next 5 minutes. So the best shot is the enhanced high dose vaccine. However, we don't have it. We have to give standard dose only. But the answer is the enhanced high dose is the better choice. The last three are the RSV, pertussis, and the COVID-19. We have seen that both the vaccines, whether it's the GSK or the Pfizer vaccine, both have the marked reduction in the respiratory virus-related pneumonia as well as the bronchopneumonia prevention. Home to adults, we already learned it. Similarly, RSV in adults, we have the URI prevention, hospitalization markedly increased with the RSV. It's all we have learned so far. Pertussis and COVID-19. Pertussis, as mentioned, one adult Tdap to be given. Pregnancy is the best way to protect the newborn, and chronic respiratory disease are the more vulnerable, should be receiving it. COVID-19 booster dose, if available, should be given to the elderly population. As I already mentioned, COVID-19 vaccine in India today, current scenario is we have outbreaks in Andhra Pradesh, Karnataka, and Kerala, but unfortunately, we don't have the vaccine available. COVID-19 and pertussis burden mortality and the outcomes. So cyclical episodes are always there, whether it's a COVID-19 or it's pertussis. But the COVID-19 has become now an epidemic or endemicity. However, the pertussis outbreaks are after every 5 years when the immunity goes away. This is what we are matching the vaccine to the best of the underlying diseases. COPD, conjugate, pneumococcal, asthma, again same, immunocompromised, again the special schedule, especially with the immunocompromised, whether to give polysaccharide or to give the conjugate. Same with the elderly more than 65. For influenza, enhanced vaccine to be given in the elderly more than 65. The rest is almost same. And access and affordability, the cap is definitely there, and UIP for the childhood is the best way to cover the I would say pediatric population. But for the adult, we need to go with the our own pocket to vaccinate our adult population. HIP, the last vaccine, it is indicated only in the asthenia, splenectomy, and the sickle cell disease. However, the non-typeable H influenza, which is the most common reason for the pneumonia in the adults, there is no prevention by the HIP vaccine, because HIP is a type B vaccine. But most common exhibition by in the COPD patient are the non-typeable. You will not get the benefit by just vaccinating the HIP vaccine. The 4 key clinical steps which we need to give see before we vaccinate it: screen and identify the patient, recommend clearly, co-administration at the same time, and document as well as the recall which vaccine to be given and what to be given at the same time. So 3 quick questions before we close. What age does ACIP now recommend the pneumococcal conjugate vaccine for adults? Which influenza vaccine is preferred for 70-year-old with COPD, and can influenza and pneumococcal vaccine be given at the same time? This is what the answer is. We already learned all these things. Final take-home message is immunization is core respiratory medicine, pneumococcal conjugate first, and influenza every yearly for everyone. RSV, pertussis, and COVID complete the schedule. And your recommendation is the first intervention for the patient. With this, thank you very much. Protect the lung before it is attacked. Back to Dr. Ekta and back to Dr. Chawla. Thank you very much.
Thank you, Dr. Ahuja. It was a very extensive, elaborative, and very nicely presented talk, and good to hear from an ID person so much about the viral structures and how the vaccine made such a nice presentation. I think there are many questions in the chat box, and we will quickly stick to the. So I'll ask both the expert the answers, and I think we should stick to the time. So, Dr. Chawla, you have to add anything onto this? How do we go about the
No, I think we will just, they can be short in their answer whenever they give the answers to the question.
So let's be very short. So the first question, I think
we can cover more.
Yeah, Dr. Bansal, how do you clinically differentiate viral pneumonia from bacterial pneumonia at the bedside before the reports are available?
So, first of all, we have to start from the history. History may or may not be very good in differentiating, but any history which starts with the history of URI, like nasal symptoms, and history of having sick contacts. Plus, you know that currently in the season in your surroundings there is a lot of respiratory viral infections are there. All these three ticks in, then most likely you are dealing with a respiratory viral infection. If that is not the scenario, like in Delhi, I practice in Delhi. So in Delhi, if you are in a dry weather, dry time, then most likely it may not be the respiratory viral infection.
Yeah. So if the viral diagnosis reports are not available, you cannot. However, if you have the CBC available, some hint about a bacterial cause can be there. Second question is the role of multiplex PCR respiratory panels in ICU decision making in India.
So, as I discussed in my slides also, I think if you are having a patient with diagnosis of community-acquired pneumonia, then definitely in ICU settings, if your resources allow, you definitely should test these patients for syndromic respiratory viral panels. Multiple reasons. First, you will get a diagnosis, you can isolate the patient, you can start on specific antivirals. Secondly, you can de-escalate on antibiotics and prognosticate the patient accordingly.
Especially in the ICU setting, the multiplex panel are very, very good, because you just don't want to bombard your patient with so many antibiotics. Third is, when do you start empirical oseltamivir in a suspected influenza pneumonia patients, and do you wait for confirmation of the test? So
in this day and age, I don't start empirical, because the syndromic testing results are available within 2 to 3 hours in my area of practice. Like where I work, if I order a test, it will come in 2 hours, whether it is middle of the night or in during the working hours also. Otherwise, you need to know the current epidemiology of the area which you are working in. If your influenza cases are very high in the number, it's peaking, then you can decide to give empirical oseltamivir till the reports come. But in routine day-to-day practice, I don't give empirical, because the reports come in 2 hours. So that 2 hours don't make a difference. We can decide after 2 hours.
Very fast they come, and yeah. So you, add on to it, you'd still categorize A, B, C as per the national.
Definitely, ma'am. Because we are not going to test for everyone. The test is costly. So if the patient is immunocompetent, patient is fine, we are not admitting the patient is a category A patient, definitely no need to test. But if the patient is getting admitted for whatever reason, or if the patient is severely sick, then definitely test is required.
Okay. So next question is again to you, that how do you approach a patient with COVID-19 pneumonia who deteriorates after day 7? So is it a viral progression or a secondary bacterial infection
Actually, this question is very, like, I mean, I would say very contextual. At what time of COVID-19 you are managing these patients? If you ask me today, then the reason for the patient deterioration would be something different. Like must be something co-infection by a bacterial pathogen or by a fungal pathogen. If that was in 2021, then I would have said it is COVID related. CRS would have managed in that way. So, I mean, per se, I don't think this question is very pertaining to today's practice, because now COVID-19 is, we are seeing cases, but they are not cases which is leading to pneumonia. They are minor URIs only, which settle down on its own.
And more so, like, and this next question, which I think this can be combined, is that what is your threshold of suspecting a co-infection in a critically ill? So normally a viral infection will proceed, and after day 5, still by the entire, nebulization and all those, the patient is not improving. So you should start, and there is a comorbid patient, you should start suspecting that something else, and the CBC count will also let you know that the patient is deteriorating. So, is there still a role of steroid in severe viral pneumonia outside COVID-19, like in influenza or RSV? Or do you prescribe steroids for?
So, the role of steroid overall in community-acquired pneumonia has now been proven. So, we have trials in NEJM and other high-impact journals which have proven that empirically you should give steroids in these patients, particularly if they are admitted to the ICU, severe community-acquired pneumonia. But for per se, if you have proven that they are viral, then there is absolutely no role of which can lead to improving mortality. So I don't think we should give them. But if you're treating community-acquired pneumonia as a syndrome, like which we as clinicians mostly do, because we don't find the pathogen in many of these cases, then you can choose to give steroids empirically in patients who needs to be more studied or explored further.
And I think the concept of inflammation and causing the deterioration of your pneumonia and landing, that needs to be so a study which COVID has actually shown that what is the role of steroids, and hyperinflammatory response in these viral infections needs to be studied, and how so that inflammatory response can be controlled by the steroid. If the pathogen per se is not cytopathic that much. Okay, so the next question is, how do you manage RSV pneumonia in adults, especially the elderly and immunocompromised? I think you shared in your slides.
Immunocompromised patients with developing RSV pneumonia very difficult to manage, because RSV is a difficult pathogen to treat. We can use ribavirin. Ideally, the route of delivery will be aerosolization, but that is difficult to procure and very expensive also. You have oral ribavirin available in India because we used to give it for hepatitis C earlier. So still some companies are making it. There are softer recommendations. The level of recommendation is very weak. I have used it quite a lot, but I frankly believe that it's not a very good antiviral agent to be used for RSV. For patients who are suffering from B cell defect arm, like CVID patients or CLL patients, which I described in my case, you can choose to give IVIG also, particularly if you have picked up the RSV infection prior to it has affected the lungs, like it is a URI still, and the patient is immunocompromised, like CLL or multiple myeloma. You can give prophylactic IVIG to prevent the progression of disease. That's what we can do. And I think Dr. Jatin also spoke about some monoclonal antibodies which can be given, but they are mostly restricted to neonates, not for adults.
No, I mean, you see, the problem is when you get a multiplex PCR, you get a rhinovirus, you get an RSV, which one to treat? Are we going to discard? Because the symptoms are very non-specific.
Yes, sir. Yes.
Unless you are purely growing RSV, difficult to say that it is RSV, isn't it?
So definitely, sir, that is a scenario, but I mean, it can happen, but it happens in 1 to 2% of the cases. Not in every case you're going to have a co-pathogen in respiratory symptoms. Rhinovirus can be a commensal. I mean, I know it's a pathogen described as pathogen, but rhinovirus can be a common nasal commensal, so that can be ignored if you've identified some other pathogen as well.
Yeah, so interestingly, the biofile panel is the one which is the multiplex panel available. Now more are coming. So that identifies rhinovirus and and query enterovirus kind of a situation. But sometimes isolated rhinovirus and there is a patient with comorbidity that itself can be. So that clinical decision has to be taken. That if you have an RSV and rhinovirus, let RSV, you consider RSV as a pathogen. Influenza and rhinovirus, let influenza take the lead, which is a stronger virus than to report. So, what atypical organisms should we routinely suspect in non-resolving community-acquired pneumonia in the Indian settings? There's a
Whatever
non.
I have learned is in last 3 4 years is mycoplasma is definitely top on the cards. Although we keep hearing about Legionella, but that is I think pertaining more to Western literature or the books which we read in our student days. But I think mycoplasma has come up really high over the last 2 3 years, and it's definitely in Indian scenario we need to keep it high. Another lacuna is that because our mycoplasma is mostly macrolide resistance, so empirically azithromycin, which is generally given as a part of community acquired pneumonia antibiotic cocktail, may not work for mycoplasma. So generally won't work. Not may or may not, it won't work. So you have to give other tetracyclines to treat mycoplasma. So mycoplasma definitely high. I have not seen Legionella or chlamydia proven cases in my practice as of now.
The next question is, I think, how reliable are atypical serologies of mycoplasma chlamydia in Indian labs, and do you trust them clinically? So they are not.
They are not very trustable, and I would not say that you should use them unless and until you are having a non-pulmonary complication of mycoplasma, like a cold agglutinin disease or something else, like encephalitis and all. From a lung standpoint, definitely you should not rely on serologies. Go for PCRs if you're suspecting, or treat empirically.
Even for the other pathogens like influenza, those antigen assays, they have no value. Now, the next question is approach to empirical macrolide or doxycycline coverage.
He's already answered this.
He's already answered that. Now, how do you distinguish adenovirus or parainfluenza pneumonia from more common viral causes in the adults? I think multiplex PCR is the way, and they have specific targets, so that is the only way you can distinguish. Is there a role of antivirals in non-influenza, non-COVID viral pneumonia?
Only 2-3 pathogens we can give an antiviral, like influenza A or B. And then COVID and then RSV. The rest all pathogens we don't have a specific antiviral agent. So whatever antiviral agent describes, that is more of a case series or case report based, not evidence based. So yes, people use oseltamivir for parainfluenza also, and sometimes ribavirin for other viruses, but they are not evidence based guidelines recommended. They're just anecdotal evidence.
I think this Dr. Chawla has already answered, and he can dwell more on it. How do you manage a ventilated patient with viral pneumonia who develops ARDS? So, difference in the ventilatory strategy.
Out of my syllabus, no.
Does the ventilatory strategy for an ARDS or
no,
Sir,
ARDS strategy for a patient who develops a viral pneumonia is like for any ARDS patient, that is a lung protective ventilation with low tidal volume, then give PEEP according to the FIU table. That's what we do. And if the plateau pressure is high, if you're so much interested, then probably you need to keep it below 50, and if PCO2 is rising, raise the respiratory. So I think we can go to Dr. Jatin and ask him some questions.
I think enough of this. So, Dr. Jatin, which respiratory vaccines do you prioritize for elderly patients with COPD or ILD in India?
He's answered this, I think.
He's answered in the slide. And what is your recommended pneumococcal vaccination strategy, PCV versus PPSV 23, and sequencing between them? So you've already answered, but I think pneumococcal is always a confusion. You can repeat this.
So I would like to emphasize that earlier definitely there was a confusion between the polysaccharide and the conjugate. So these days the things have become very simpler after the introduction of the PCV 20.
Louder, please. Louder.
Yeah. So after the introduction of PCV 20, the things have become very clear. So you have to give just single shot and then forget of everything. But the candidates who have already received the PCV 13, they are the one who should be getting the PPSV 23 at least after a gap of 1 year. If there is a very immunocompromised status is there, it can be given after the 2 months.
With dehydration,
And there are candidates who have received earlier polysaccharide and not the conjugate. The vice versa can be done after a 1 year of the gap. The PCV 13 or PCV 20 can be given.
ಬಟ್ ಏಕ್ಸಸ್ ಬಗ್ಗೆ ಹಾಕೊಂಡು ನೀಟಾಗಿ
So I think the next question is what I also feel very it's close to my heart, that how will a consolidation of annual influenza vaccination in a country without a strong national adult immunization program. I think a latest survey which was published by European Union has shown that post-COVID, the influenza uptake in United States and European countries have risen. But COVID vaccination, RSV awareness, all this has gone down. And especially in India, we really don't have a lot of awareness and campaign about the adult immunization program. Dr. Jatin, would you like to add on to it?
Yeah, sure, ma'am. So, seeing the immunocompromised patient, like especially the HIV, so seeing the immunocompromised patients, sir, especially the HIV and other post-transplant or post-chemotherapy receiving, they are the one who keep on getting the either the bouts of the exacerbation of the respiratory symptoms, or they are having the hospitalization. So once we start counseling them that you should read about it, once your this exhibition get over, I'm going to advise you the flu shot. Definitely you read it and then get back to me. So if we give them the open choice, so they are the definitely the patient who read about it, because these days we have the AI. So they definitely go and read about it and they ask you. And since the vaccine cost has become cheaper after the removal of the I would say Yamagata strain, so most of the patients they start saying that Dr. Saab, I need this vaccine, when to be taken. So I recommend them prefer to take before the monsoon. Since if the patient is coming after the monsoon, I tell them that this is not the right time, and already you had the recent monsoon post-viral infection. Whenever the next season will come, I'll update you. But I'll update you, but you can come to me. This is how I counsel them.
But somehow I think, Dr. Jatin, whenever they come, you need to get them to the vaccine. So get them a vaccine. Once they get used to, then on next time you can. If you say come pre-monsoon, he will never come. So you get him that you have to get every year. That's what I do. Once they come, when they're getting discharged or in the OPD, you just get them hook on to the vaccination. Once they are hooked on, every year they automatically they want on their own they will ask for vaccination. That's what
Also,
the
that is
practice.
also right, and I would say ideal approach. But most of the patients they are initially reluctant. So I ask them to read about it. They are spirited.
Patients now everyone takes them, and similarly before discharge, another advantage is people on insurance they want the injections to be given. So that's the time when the pneumonia is getting discharged. I get them vaccination. That's my usual practice, and I found that there is no reaction, and we get them before discharge to vaccine. Even pneumococcal also, along with too many patients.
I think we need to take it up at a larger scale, because those with the comorbidities, we see a lot of viral pneumonia cases and the liver disease patient cracking down into liver failure very fast because of the non-hepatotropic approach of these viruses. So those with comorbidities should be vaccinated with influenza and if RSV comes. Is RSV vaccination relevant yet for the Indian adult population, and whom should we prioritize?
So as I mentioned that the RSV vaccination is meant for the adults who are more than 75 years of age or more than 60 who already had the disease, underlying comorbidities. But unfortunately, we don't have the vaccine. Many times we have seen the patient who have the bilateral lung ARDS, but we don't have the other bacterial pathogen, only the RSV identified on the multiplex PCR. They are the definitely candidates who might be get benefited if they will be vaccinated from the RSV vaccination. Maybe in the future we can have hope for the getting the RSV vaccine, especially for the immunocompromised patient who are 60 plus.
I think if we move ahead, we see a lot of 18 to 59 years, after influenza, the next common cause of pneumonia is RSV from our data, at least. So it should be. Yes, sir. Dr.
So, now the gold, they give guidelines for COPD. So they recommend you need to give influenza, you need to give pneumococcal, shingles, Tdap, RSV. So that's their revised this year. They have included even RSV also there, and shingles. That I have started giving to patients. It is only 2 doses, although a little expensive. But when a person elderly gets this, the pain,
फ्लक्चुएट करेगा
neuralgia sometimes are very devastating.
बीपी
So
फ्लक्चुएट
two
करेगा
doses, one
डिहाइड्रेशन
first
से।
dose, and after 2 to 6
ये
months,
थोड़ा
you
दवा
give a
लिख के देता हूँ, वो दे
second
दो।
dose.
गर्म पानी
That
पीने के
also
लिए
is
देना है।
included.
3
I
से
mean,
4
when you give
लीटर पानी
vaccine
पीने
to
के लिए
these
देना है,
COPD
और
patients.
पान नहीं खाना है।
So the evidence of COVID-19
और ये
booster
दवा लिख
doses
के
in
देता हूँ,
immunocompromised or
वो
elderly
2-3 दिन दे दो।
ICU survivors.
क्या नाम है?
Are you vaccinating against COVID-19, Dr. Chawla, from your ICU?
No, we are not vaccinating. And somehow we are seeing very little of COVID now. And I think
बीपी
most
के
of
अलावा
our
कुछ दूसरा
population is
दवा
already
खाती हैं?
vaccinated. And I have others, I have influenza and PCV20 to give them,
गर्म
Prevana
पानी में
22,
थोड़ा नमक डाल
so
के
that
गार्गल कर लो,
I,
वो गला
I
जल्दी
want
ठीक
them
हो
to take
जाएगा।
that because they're expensive.
हाँ,
Although
पानी पियो,
I am yet
पान
to
मत
find
खाओ।
out the rates of influenza vaccine, but as Dr.
ऐसा देख
Jatin
रहे
is
जैसे
saying, if it's
किडनी
got
मांग
cheaper,
लिया।
naturally it will get a wider coverage. But the other one is still expensive for people to take it.
And COVID-19 is that they have upgraded the strain of circulating strain, whether the updated strain, so there's no point in previous COVID vaccine booster dose. So how do you handle vaccine hesitancy among patients, even the healthcare workers in your practice? Dr. Jatin?
मुंबई में अभी तक 12 केसेस मिले हैं
Definitely, ma'am,
कोविड
in
के।
our Apollo, we have a
आंध्रा में
dedicated,
सबसे ज्यादा मिले हैं, 18
I would
केसेस
say,
और 4
the
डेथ हैं।
program in which the, like, I would take example of
अभी वेरिएंट
shingles.
डिक्लेयर
So
नहीं
all
हुआ
the
है।
50 years plus and
जिसका डेथ हुआ है
consultants,
उसको
they have
ओमिक्रॉन
been
जो कि
given the
वो
choice and
थर्ड
option
वेरिएंट ही
to
था
take
वही
the
है, न्यू कुछ भी नहीं मिला
shingles
है
vaccine
अभी तक।
also, and all the healthcare workers, whether irrespective of the whatever status they are, they have been given the choice to take the flu
बोल
shots.
नहीं सकते
So
हैं
most
कब
of the
क्या हो
I would say
जाए।
healthcare workers, they adapt it. I hope Dr. Chawla must have taken it, the shingles also, because everybody, I think 50 plus have received it. But those who are less than 50, they have given the option of flu shots. It is from the institution which has to come from that. They are the vaccines
डिहाइड्रेशन
for
की
the
वजह से,
based on their
स्ट्रेस की
age,
वजह से, वो
based
सब
on
की
their
वजह से आता है।
comorbidities, they should
अगर दवा
receive
नहीं
it. Like
खाया है
hepatitis
तो
B,
भी
it's a
बढ़ता है
mandatory
दवा के
as soon as the patient, not a patient, as soon as any healthcare worker joins any institution. Hepatitis B is the recommended vaccine to be taken.
एसपी मॉर्निंग आफ्टरनून नाइट।
So what roles do vaccines play in preventing recurrent hospitalization and
मॉर्निंग
COPD and
नाइट,
bronchiectasis
एंटीबायोटिक
patients?
डॉक्सी
I think
100
we've
mg
already
मॉर्निंग
answered.
नाइट।
Dr. Chawla, you can.
तीनों
No,
तो
I
खाने
think
के बाद
that's
देना
we've
है।
already covered.
एंटी
You know,
एंटीसेप्टिक
Dr. Jatin, I want to ask the question.
खाने के
If a
बाद
patient
वो
asks,
3 दिन दे दो बस।
will I never
थोड़ा
get
गार्गल
these
कराओ,
these
लाइट
infections?
से
So
खाना
how do
खाने
you
के लिए
answer?
दो, काला
I just
मसाला
want to know
कोई
what do you
आइटम
tell
नहीं
them?
लेना है।
So the idea of
I think we've lost him.
the vaccine is not to have 100%.
नॉर्मल खाना
Can
खाना
you hear me, sir?
Yeah.
पान
So
नहीं
the
खाना
idea
है।
of getting the vaccination is not to get 100% rid of that pathogen. It is just to prevent the severity of the disease or prevent the complication of that pathogen. This is what I used to say to my patients. It will not that. Pardon, sir? Hello.
Yeah, so I think rightly said that it is the severity of these infections which will be prevented, especially in the comorbid. I think we don't have the internet with Dr. Chawla. We'll move on to the next question then. Are these cost-effective strategies to improve adult vaccination uptake in the Indian tertiary care hospitals? I think you've answered it in your presentations. How do you sequence multiple vaccines, flu, pneumococcal, COVID, in a single visit?
So most of the patients who have the underlying comorbidities, they have been given the options of taking the multiple vaccination. So what I do is that in my routine practice, I prefer the vaccine which is the cheaper in cost and definitely has the minimal side effect. Like if I give the shingles first, the patient will come with the pain, tenderness and fever. He's not going to take the other vaccines. So I start with the flu shot, which is cheaper, and tell them that go and read about the another 2 vaccines. Whenever you come for the next visit, we'll have these tests to be done, and then we'll give it. Ideally, this is what I go for my approach. But if I recommended all the 3 doses at the same setting, which is the ideal setting is there, nobody will going to take it. So start with the cheaper cost and the vaccine which is having the minimal side effects and which we vaccinate on daily basis, like flu is the very common one. Then I start with the hepatitis B or I like pneumococcal vaccine, and then last shingles. Because if I go with the shingles first, most of the patients have complained of the soreness, tenderness, and pain. And moreover, it's a cost, 22,000 cost for the 2 vaccine. Nobody will going to accept it.
Now, the last question I think I'll take up, and I want comments from Dr. Jatin also and Dr. Bansal also. Between improving the vaccination coverage in India, that is making more vaccines available, and improving the antiviral treatment access, what do you think we should move towards as a country? Should we move towards antiviral approaches or vaccination? Dr. Jatin first.
So both are required. One is for the definitely treatment perspective, and another is for the prevention perspective and complication perspective. So both are definitely in the, I would say, armamentarium should be there, but it depends upon the what kind of virus we are targeting it, and those who are can be prevented by the simple flu vaccination, they has to be there. Those who don't have the good vaccination, like we have the Nipah virus recently outbreak in the West Bengal side. So we don't have the vaccination in India as of now. So those cases, the ribavirin has to be available. So it depends upon the pathogen which we are going to target it. So it varies from pathogen to pathogen.
Dr. Bansal?
I think if you have to choose one, then I think I have to choose the vaccination access, because that is where the prevention is. Only thing which I wanted to add about what we were discussing about vaccine hesitancy is that how as a healthcare worker or as a doctor I prescribe vaccines to my patients also depends. So if I give a vaccine, if I give a advice to a patient who is suffering from pneumonia, I will say take this drug, take this medicines, you will get better. But when I give advice to my patient for vaccination, you may take this vaccination. It will help. It may help you. So I give a softer recommendation from my side. So they because I am myself resistant, so they will not take that. So the emphasis which I give on vaccination is also important. So that's why I think as a healthcare worker, as a doctor, as a prescriber, it's my responsibility to emphasize on the preventive aspects as equal as I give on the therapeutic aspects.
I think we can end.
Yeah, sure. I think we've lost Dr. Chawla. So I am, with that, I think we'll put an end to the session, and I'm grateful to you, Dr. Ekta ma'am, for brilliantly moderating the session and deliberating the questions and for the wonderful discussion. Dr. Nitin, thank you so much for your excellent talk on the viral and atypical infections. I think it is the need of the hour. And Dr. Jatin, thank you so much for clearing all the doubts and for giving us the basic strategies. And I think for the students, it is very important to know when to advise the patients to vaccinate and when to wait. And when you have a patient in the hospital, how to convince to come back for the vaccination. I think that was very important. Thank you so much for joining us today. I would also like to thank NCCP and ISCCM for endorsing this program, the Exicon team for the smooth execution, and Zymes Biosciences for supporting. Thank you so much, everyone. We'll see you next Tuesday on 28 July. And the next topic is infections of the immunocompromised host. Thank you and good night. Thank you.
Thank you.
Thank you.
Thank you, Dr. Ekta. Thank you, Nitin. Thank you, all the audience.
Thank you, Dr. Nathan. Thank you.